Welcome to a Stanford Pediatric Pulmonary webinar. I am Mimi Boo, one of the course directors for this series. I'm a pediatric pulmonologist at Stanford Medicine Children's Health, and today I'll be acting as a moderator for this session. Today's topic is pediatric lung and heart-lung transplantation. I'm happy to introduce Dr. Sissy C. She is an internal medicine and pediatrics trained pediatric pulmonologist. She is a medical director of the pediatric heart-lung transplant program at Stanford Medicine Children's Health. She completed her medical degree at Baylor College of Medicine in Texas, and she was trained in internal medicine and general pediatrics at Case Western Reserve University and Rainbow Babies in Cleveland, Ohio. She completed her pediatric pulmonary training at Stanford School of Medicine, and in addition to lung transplantation, she also has expertise in the respiratory sequelae of stem cell transplant, air digestive disorders, amongst many other conditions. Today, she will shine the light into what people outside of the field see as a black box of lung and heart-lung transplantation. Please welcome Dr. C.
Thanks for that introduction, Mimi. Okay, so my talk today, we will talk about overall trends in pediatric lung transplantation, indications and contraindications, when to refer, focus on that referral and evaluation process, as well as briefly talk about the operative and post-transplant management and overall outcomes. I wanted to start this talk with a brief history of lung transplantation in general, and to show that this is a relatively new field. So the first human lung transplantation was performed in 1963, but really only in the 80s did people survive after lung transplantation. And we have a rich history of heart-lung transplantation at Stanford, with our center being the first to perform the first surviving heart-lung transplant over on the adult side, as well as the first pediatric heart-lung transplantation here. But in the 4 decades that pediatric lung transplantation has been a field, with peak numbers occurring in the early 2000s, in more recent years, this number has shown significant decline. This is data from the Scientific Registry of Transplant Recipients for pediatric patients undergoing lung transplant under the age of 18. And you can see that after elexacaftor, tezacaftor, and ivacaftor was approved in October of 2019, for cystic fibrosis patients, there has been a decline in pediatric patients undergoing lung transplantation. This is in contrast to adult patients where numbers are increasing yearly, with more recent data showing over 3,000 patients undergoing lung transplantation in adults year over year in the United States. This graphic shows in more detail the proportion of children undergoing lung transplants for various indications, and you can see in blue that in 2020 and beyond that the number of patients undergoing lung transplant for CF has dramatically declined, and that decline has been sustained over time. And so with this steady decrease for CF, the cohort of patients undergoing lung transplantation in children have become a different cohort, with pulmonary arterial hypertension taking that lead role, as well as rising rates of interstitial lung disease. So looking at UNOS data, this graphic shows the proportion of pediatric patients undergoing lung transplantation for ILD, and that this has steadily increased over recent years, with more recent data showing about 30% of children undergoing lung transplantation for ILD indications. And so what does ILD mean? In children, the most common etiologies of interstitial lung disease include those of surfactant protein disorders, specifically surfactant protein B, surfactant protein C, ABCA3, and NKX2.1 deficiencies. I also think of ILD as those disorders that cause developmental lung disorders, such as TBX4 disease, filament A disease, FOXF1, and associated alveolar capillary dysplasia. And these conditions can present with both developmental lung disorders and alveolar simplification, as well as some component of pulmonary vascular disease. In addition, bronchopulmonary dysplasia in our patients who are born premature also are in this category. There are other indications that are in this umbrella term of interstitial lung disease, such as pulmonary fibrosis, pleural parenchymal fibroelastosis, as well as diffuse lung disease from underlying rheumatologic conditions. And so what about heart-lung transplantation? At our center, we have transplanted and considered patients for heart-lung for underlying etiologies such as bilateral pulmonary vein stenosis, distal pulmonary artery stenosis, for children who have severe pulmonary hypertension, who are on VA ECMO going into transplantation, Eisenmenger syndrome, as well as congenital heart disease with underlying pulmonary hypertension. But on the whole, these numbers are on the decline, including at our center. And to give you some more granular detail, in 2023, there was only one heart-lung pediatric transplant patient. And in 2024, there were three. And more patients are being considered for single organ transplant. For example, heart transplant with pulmonary artery reconstruction, or a bridge of vasodilator therapy after heart transplantation, or in contrast, lung transplant with pulmonary artery reconstruction. At our center, this is data looking at how many patients we've transplanted over the years. This includes our multi-organ transplants as well. And so in contrast to national volumes, in this most recent year, we've actually had our biggest volume yet in many years. I won't postulate too much as to why this is for this talk, but part of this is candidate selection and offering transplantation to patients we might not have in the past. And looking at the specific diagnoses for patients that have undergone lung transplant at our center, we mirror national data in that pulmonary hypertension, particularly when you take into account both primary pulmonary arterial hypertension as well as class 3 pulmonary hypertension. It is our most common indication in recent years. However, unlike national data, we are still transplanting a good portion of children with cystic fibrosis. And our three most recent recipients were not modulator eligible. So we know that as a whole, there is 10% of the population who are not modulator eligible. This percentage is increased in the non-Caucasian population. And so given the demographics of California in this region in particular, we do have a higher proportion of CF patients who are not modulator eligible and may ultimately need lung transplantation. When comparing pediatric patients to adult patients, we know as pediatricians that kids are not small adults. And this is reflected in severity of illness going into lung transplantation, with a higher proportion of patients needing ECMO, as well as mechanical ventilation support, as well as being admitted and needing inotropes as compared to the adult population. So in summary, pediatric patients are sicker as a group. So when should people refer for lung transplant? New consensus guidelines from ISHLT give these 4 criteria. So really disease-specific criteria first and foremost must be met. So patients must have end-stage disease. If you are thinking that they need a lung transplant, but there is a substantial barrier that needs to be addressed, such as malnutrition, psychosocial factors, refer early so that this can be overcome. Understanding transplant candidacy can impact other therapeutic options such as ECLS or ECMO. And so refer first before thinking about this as a next step. And if multi-organ transplantation is needed, refer early to think about assessment for both. These same consensus guidelines also state consideration for listing for these 4 criteria. Patients should have end-stage and progressive lung disease that has not responded to optimal treatment. There cannot be a surgical contraindication. And really, these patients should have a high likelihood of death within the next 2 years, as well as a high likelihood of survival post-transplant. So effectively, we want these patients to be sick, but not too sick. Ultimately, we want an early referral. An early referral gives us time for education, to talk about the transplant process, discussion of expectations pre and post-transplant, as well as understanding the family's desire to pursue transplant as a therapeutic option. We also want time for optimization, bulking up their nutritional status, managing their comorbidities, overcoming social and psychosocial factors, as well as a focus on rehabilitation. For patients who have high allosensitivity, this also gives us time to pursue desensitization efforts to make them a better candidate. It also gives us time to consider alternative support strategies. For example, in patients with severe pulmonary hypertension, there's time to consider a reverse POTS shunt, which is a right to left shunt offering a pulmonary to systemic shunt that allows a pop-off to preserve RV function. At our center, this is under the umbrella of the SEAL program, and ultimately allows patients time to wait for organs. And thinking about who we would not offer lung transplantation, these are absolute contraindications at our center. And this might vary some from other centers across the nation, but in general are pretty consistent from center to center. So this includes patients with active malignancy we would not necessarily consider right away. Burkholderia sinosepation, the CF population, if there is concerns for active infection, that is an absolute contraindication. Children who have poorly controlled psychosis or active substance abuse. If there's multi-organ dysfunction that is progressive and they are not a multi-organ transplant candidate. If there is evidence of refractory non-adherence, we do not offer transplantation for progressive neurocognitive decline or severe neuromuscular disease. And if the patient and family do not consent for transplant, we would not offer. There are also a whole host of relative contraindications that might make the surgery more complex, but having one or a few of these do not make a candidate do not pretend for candidacy. And so these include things like reflux, esophageal dysmotility, colonization with NTM, Aspergillus, or MDR organisms. For NTM, we are more worried about smear positive M. abscessus as compared to colonization with MAC, for example. If there's concerns for nutritional status, both markedly low BMI or markedly high BMI, comorbidities such as poorly controlled diabetes, severe deconditioning, a prior history of pleurodesis or chest wall or spinal deformities, refusal of recommended vaccines, and high allosensitization. Being on a ventilator pre-transplant or being on ECMO pre-transplant or needing a transplant for retransplant, these all portend higher risk, but are not absolute contraindications. Similarly, a history of anxiety, of depression is not a contraindication. Many of our patients have underlying mental health concerns. A lack of insurance and unknown immigration status. Insurance and financial considerations are managed through our transplant finance department and should not preclude referral. A history of underlying autism and developmental delays. We've certainly overcome this in the past. Low socioeconomic status. A history of repeated thoracotomies or sternotomies in the presence of a tracheostomy tube. These are all things that we have overcome and have undergone successful transplantation for children in the past. So in thinking of more specific criteria for referral and listing, there are markers of shortened survival that have been published. This is markers that have largely been validated in the CF population and specifically in adults, but can provide some guidance in children as well. And so this includes a low 6-minute walk distance, specifically under 400 meters, having daytime or nighttime hypoxemia that is unable to correct fully with activity, having significant hypercarbia and need for non-invasive or invasive ventilation, daytime and nighttime, as well as the presence of pulmonary hypertension in the setting of end-stage primary parenchymal lung disease. There are certain diagnoses such as alveolar capillary dysplasia and surfactant protein B deficiency that we want to know about as soon as possible, given that patients with these disorders often need lung transplant early in infancy, as well as certain diagnoses such as pulmonary hypertension from pulmonary veno-occlusive disease that do not tend to respond to vasodilator therapy, and lung transplant still is the only long-term therapeutic option. And at our center, we do a lung transplant evaluation for all patients undergoing that reverse POTS shunt placement. Specifically for pulmonary hypertension, if a patient has severe pulmonary hypertension and remain in that high-risk category despite maximal therapy, and maximal therapy is defined as being on triple therapy with one of them being a continuous infusion, you should think about referral. And this is the consensus guidelines out of the European Pediatric Pulmonary Vascular Disease Network. So thinking about what makes a patient with pulmonary hypertension high risk, this includes a reduction in cardiac index, significant functional limitations, and elevated RA pressure, and ultimately progressive RV failure. And thinking about cystic fibrosis, the Cystic Fibrosis Foundation had previously put out guidelines for when to refer and when to think about listing. And this includes things like an FEV1 under 50% with a rapid decline, which includes greater than 20% decline in the last year, greater than 2 exacerbations or increasing exacerbations over time, things like massive hemoptysis and pneumothorax, in consideration of referral if the FEV1 is under 40%, in consideration of listing if an FEV1 is under 30%. However, in the advent of highly effective modulator therapy, some of these criteria may not translate to children who are modulator eligible. But like I previously stated, in the state of California, we do have a substantial number of patients who are not modulator eligible. So I do think of these criteria as guideline for these patients. Now that you've referred, what does that evaluation process look like? So there is a lot of lab work, first and foremost. Most of this is mandated by UNOS and needs to occur. We like to have lung function testing in children who can undergo lung function testing, including comprehensive PFTs and a 6-minute walk. There's a whole host of different imaging modalities, procedures, including a pH impedance probe, and consultations with numerous other subspecialties, as well as assessment with our core lung transplant team, including an assessment by our social worker, our psychology colleagues, pharmacy, dietitian, our nurse coordinator, and the transplant pulmonologist. This all takes place on average. An outpatient evaluation takes about a week or so to fully complete. And on the inpatient side, it can happen a little bit quicker, but at minimum 3 days. And our lung transplant evaluation assessment, as well as the post-transplant course, is certainly a team-based approach with a whole host of people that are involved that do not only include the transplant pulmonologist and the transplant surgeon. In thinking about pediatric specific considerations, most children who are undergoing a lung transplant cannot formally consent, and many cannot assent for lung transplant. So thinking about the family dynamics and the family support for these children who are undergoing this very complex therapeutic option, thinking about the child's developmental status at the start of the transplant process, as well as potential for growth and improvement over time, their growth trajectory, as well as the ability to obtain childhood vaccines. Specifically for the infants who undergo lung transplantation, sometimes some of these vaccines, specifically the live vaccines, cannot be obtained prior to transplant. The timeline from referral to evaluation and ultimately listing can happen in weeks if it's a very rapid process for someone who is very sick and needs to be listed quickly. But more common than not, this process lasts on the order of months and sometimes even years. Many of our patients have a period of optimization or deferment from that evaluation to listing timeframe. And before we pursue listing, our families do have to relocate to within a 4-hour distance of our hospital before activation. And so this 4-hour distance from the hospital, generally that means driving, although we are entertaining more and more the idea of a door-to-door flight time, given some of our patients with complex needs prior to transplant. Now, what happens once a child is on the wait list? So UNOS, which is the organization that oversees organ donation in the United States, has transitioned to a continuous distribution system of organ matching in 2023. So what this means is that there is a unique composite allocation score that is calculated for each potential donor-recipient match. And so these are the categories that are included in that CAS score, with some categories remaining static between each match, while others change with each match run. I have highlighted that there is a strong pediatric advantage, but this advantage is largely included to level the playing fields when we think about the paucity of pediatric donors when compared to adults. And thinking about how long candidates wait for lungs, most patients do get a transplant within 90 days of getting on the wait list. But you can see over time that that proportion is declining and that more and more patients are waiting longer, with some patients on the wait list for over years. I've talked a little bit already about how our pediatric patients are sicker than our adults patients. And there is an increasing number of patients needing invasive or non-invasive ventilation, significant nitric support pre-transplant and vasoactive support pre-transplant. So ultimately needing ICU care going into transplant. So we do need strong collaborations with our ICU team, and everyone should be in agreement to pursue lung transplant. There's also consideration of ECLS strategies, so whether that is VV or VA ECMO, and ideally in an ambulatory state, so that we can focus on stabilization, improvement of rehab and nutritional status, while a candidate can maintain transplant eligibility in this time frame. But of course, thinking about these ECLS strategies, there is heightened risk of bleeding, thromboembolic events, infection, and end organ damage that may ultimately lead to removal of from the transplant list if these things arise. So now we're getting into the transplant. And so at our center, all of our patients undergo a bilateral lung transplant. So we do not do single lung transplants here. The surgery can be done en bloc, meaning that both lungs are connected distally at the trachea, or more commonly, we perform something called a bilateral sequential lung transplant, in which the left lung goes in first and then the right lung goes in second. And these patients have a bronchial anastomosis. Patients can undergo the transplant surgery either through a median sternotomy, which happens at this center, or can be done through a clamshell or bilateral anterior thoracotomies, which can be performed at other centers. After the transplant procedure, all patients go to our cardiac ICU. And so what are our post-op goals for these patients. From a ventilator strategy standpoint, we like to ventilate with a low volume strategy and a high PEEP strategy. And we do the tidal volumes based on the donor ideal weight and not the recipient weight. We also ideally like to use the least amount of oxygen as possible, preferring a high PEEP strategy and use of nitric to help with that oxygenation. And if all goes well, our goal is to extubate by post-op day 1. We want to focus on rehab as soon as possible. We like the lungs to be as dry as possible. And we want to feed as soon as possible and focus on that nutritional piece with clearance by our feeding therapy colleagues before introduction of oral feeds. A lot of our patients do need some degree of positive pressure after that initial extubation, but most of our patients are able to leave the hospital and wean off of positive pressure before discharge. In the early postoperative phase, most of the complications are surgery related, including things like airway issues with dehiscence, stenosis, and development of bronchomalacia. There can be sternal wound healing issues. It is not uncommon to have some degree of recurrent laryngeal and phrenic nerve paresis, which can lead to vocal cord paresis and diaphragmatic paresis. And from a graft standpoint, we are constantly monitoring for development of primary graft dysfunction. So what is that? So this is a syndrome of acute lung injury early after transplant, and it is diagnosed in the first 72 hours after transplantation. We really don't know why this occurs, but is felt to be related to an ischemia reperfusion injury and is diagnosed based on that P to F ratio. So what is their PaO2 compared to their FiO2 needs? There is grading of what primary graft dysfunction is, with the lower P to F ratio being more severe. And ultimately, this is a diagnosis of exclusion, meaning you really have to rule out other things that can make a P to F ratio low in consideration of early ECMO if this is something that is felt to be an etiology. For our patients, they receive a lot of immunosuppression going into the transplant surgery, as well as ongoing maintenance therapy. In more recent years, we've transitioned from using ATG to basiliximab as our primary induction therapy and have noted a much less cytopenias in our patients in that initial postoperative period. Patients get very high methylprednisolone pulse intra-op, and patients are supported on tacrolimus, mycophenolate, and prednisone as triple therapy as first line. And really the goal of immunosuppression is prevention of the antigen presenting cell from sensing that the graft is foreign. And so patients are on immunosuppression, yes, but they are also on a whole bunch of prophylactic medications given that they are on immunosuppression. So all of our patients are on CME, PJP, fungal prophylaxis. They're on a PPI and azithromycin. Not all of these prophylactic medications are lifelong, and it depends on some of the risk factors in terms of what is their CMV status going into transplant. But being on immunosuppression long-term also has side effects, and patients can develop hypertension, diabetes, hyperlipidemia, osteoporosis, which ultimately may need more additional medications. So I describe lung transplant as a therapeutic option. You're essentially trading one disease for another disease, and patients are on lots of medications that are needed to be on lifelong. PTLD is something that certainly can develop post-transplant, given the need for immunosuppression with treatment requiring chemotherapy. And so for surveillance testing for these patients, patients undergo lots and lots of surveillance, including lab work, lung function testing, surveillance bronchoscopies with BAL and transbronchial biopsies. They get a lot of imaging done, and we are also starting to do in all of our patients more non-invasive monitoring with cell-free DNA testing, which is a blood work that assesses for donor-derived cell-free DNA, which can be a non-invasive way to assess for inflammation and ultimately hint at rejection before needing to undergo that surveillance transbronchial biopsy. And what are we looking for? In the acute phase, we're looking for acute lung allograft dysfunction. So this can be cellular in nature. Our transbronchial biopsies are looking for lymphocytic inflammation, which is graded as high grade or low grade, as well as acute cellular rejection, which is graded from minimal A1 grade all the way up to A4 grade under histology. If this is seen, then treatment is T-cell mediated with increased immunosuppression, typically steroids, either a pulse steroid or a prolonged steroid taper. Other complications that can occur include antibody-mediated rejection, which is more of a humoral rejection. And this is the etiology that presents when the B cells produce antibodies directed against the donor lung antigens. These antigen-antibody complexes can form, which leads to an amplified immune response through complement-dependent pathways that ultimately lead to graft dysfunction. Diagnosis of this is complex and includes a combination of elevation of donor-specific HLA antibodies, abnormalities seen on lung histology, including capillaritis, arteriolitis, or bronchiolitis, as well as C4d staining positivity, as well as allograft dysfunction. For me, at our center, we tend to start treatment, sometimes something simple as IVIG, before that allograft dysfunction is seen, given that we know that the donor-specific antibodies tend to develop earlier on before graft dysfunction is seen. And treatment is antibody and B-cell directed. So some common options for treatment include giving rituximab, which helps to inhibit the B cells. Other things like bortezomib, which inhibits which is a proteasome inhibitor, which inhibits the plasma cells from forming, as well as removal of antibodies with IVIG and plasmapheresis. And ultimately, at the end of the day, the goal is really to prevent chronic lung allograft dysfunction, or CLAD. This is primarily a clinical diagnosis and is defined by persistent FEV decline of at least 20% from baseline values. CLAD can be, there are different phenotypes of CLAD. We typically think of it as an obstructive picture, which is the development of bronchiolitis obliterans. And so essentially the bronchioles completely obliterate down. And this presents as significant air trapping on imaging. But there is an entity called restrictive lung allograft syndrome, which presents more as an interstitial fibrosis picture and distorted alveoli, and imaging shows significant parenchymal involvement. And a lot of patients can have a combination of both. And so how do we manage CLAD? Well, again, it's increasing the immunosuppression, specifically T-cell directed. Often we'll use something like ATG. Most patients are on azithromycin from early on to try to prevent CLAD from developing. Patients can undergo photopheresis, which is a therapeutic option that actually takes out and irradiates the T cells from the patient's blood. Other things that can be tried include antifibrotic therapies, using things like ruxolitinib or belumacidil, learning from our stem cell transplant colleagues. But ultimately, these treatments at best slow or temporarily halt the loss of lung function. And at the end of the day, we're wondering whether this patient needs another transplant. And so thinking about when does this occur and how long do patients survive after lung transplant? We know that over time, survival is improving over the years. And in its current state, about 90% of patients survive that first year post-transplant. And thinking about what increases the risk of poor survival in that first year, data from the ISHLT registry largely did not find anything significant, although needing a transplant off ECMO or chronic ventilation trended towards worse outcomes. When we look at outcome data comparing pediatric patients to adult patients, this data now is a little bit old, but on the whole, there's no difference between survival between pediatrics and adults, and the median survival is about 6 years. However, we know that if patients survive beyond that first year, the conditional survival actually increases to about 9 years. Ultimately, though, why do patients die after a lung transplant? The great majority of them pass away due to development of CLAD, and underneath that CLAD umbrella, largely due to the presence of bronchiolitis obliterans. And in thinking about when does bronchiolitis obliterans develop, on the whole, most people develop this by year 5. But comparing earlier eras to more recent era, we can see that the development of BOS has improved in the recent era. So in thinking about the future direction of pediatric lung transplantation, we know that there is a significant change in our pediatric population, particularly now that children with CF, on the whole, are not needing lung transplants anymore, that the kids that are now coming to us are younger and sicker. These children tend to be in the ICU more frequently. So thinking about how we can closely collaborate with our ICU colleagues for supporting these children both pre-transplant and post-transplant. At our center, we are seeing a lot more referrals for non-pulmonary indications for lung transplant, including patients with tetralogy of Fallot, pulmonary atresia, and MAPGUS. So as a pulmonologist without cardiology training, definitely need close collaboration with our cardiology colleagues as we take on this patient population. And we know that pediatric donors are a scarce resource, or pediatric patients can wait many months and sometimes even years for a good donor. So how can we think about expanding that donor pool? Things to consider for the future, and that some centers are already doing, including accepting donation after circulatory death, increasing use of procurement devices such as LungGuard or BarrelGuard, which we do use consistently at the center, using ex vivo lung perfusion to help optimize more subpar donors, as well as thinking about how to use ABO incompatible donors, not only in our infant patient population, perhaps for some of our toddler patients as well, and lobar lung transplantation. So taking a piece of an adult lung and transplanting that into a pediatric donor. And ultimately, how can we prevent CLAD so that these patients who are transplanted early in life can live into adulthood? I don't necessarily have the answers to that, but things that I ponder as I take care of these patients. And so really the take-home points of this talk, we know that candidate complexity continues to rise. If there's one thing to take home from this talk, I urge anyone who's on this call who refers for lung transplantation to refer early. We like to know about these kids sooner rather than later, because these early and thoughtful candidate selection does improve outcomes. Lung transplantation is definitely a team sport, and that multidisciplinary team involvement is essential. And there are ongoing efforts to improve both long-term outcomes as well as to reduce our donor wait times. And so, ending on a high note, these are some of our patients that have recently undergone lung transplantation. We have had one patient who was able to be honored in the Rose Bowl parade and get to sit on the float for Donor Network West. We've had a patient honored at a recent Stanford men's basketball game. This is one of our patients giving a talk at her high school graduation, and she's now in college. And a more recent patient who was highlighted after undergoing lung transplant with pectus repair, and is actually one of the youngest patients to undergo this procedure. And at the top left, siblings who underwent lung transplant and who are now 8 and 11 years post-transplant. So that's all I have. Happy to take questions if there are any from the audience.
Thank you, Dr. C, for such a comprehensive review of pediatric lung and heart lung transplantation, all the way from the history to post-transplant. So for the attendees, please use the Zoom Q&A feature to ask your questions, and we have time to answer them in real time. So again, thank you for covering, Dr. C, both the consensus guidelines on referral to a lung transplant center, and also covering our center-specific guidelines on selection. You know, the contraindications for lung transplant likely vary from institution to institution. So as our audience pool is likely from multiple places, how should clinicians consider referring to patients to transplant? Should they think about just one center? Do they refer to multiple centers with the chance of potentially being listed and getting transplant earlier? What are the advantages and disadvantages of this approach?
Yeah, that's a great question. And there are certainly patients that I hear about that have been referred to multiple centers. And in fact, you know, pediatric lung transplantation is a small field, and most of us know each other across the US and internationally. So we actually talk about patients, challenging patients, and who would be a candidate, and refer to each other if a patient is not a candidate at one center and perhaps a different center would consider. Unlike in the adult population, where a patient can be evaluated and listed at multiple different centers, in pediatrics, it's a little bit different, just given that you do have to be within that 4-hour window of the transplant center. And for us, we're the only pediatric lung transplant center in the Western United States. But certainly, patients can be evaluated and assessed at multiple different centers.
Another related question would be for the older teens or young adults. Do you sense that there's an advantage to refer to an adult center versus a pediatric center?
Yeah, I mean, certainly there are a lot more adult centers who will offer lung transplantation for the older adolescent patients. And depending on the patient and their family, I think that is a perfectly reasonable approach, particularly if they live far away from the, for example, from our pediatric center. I will say that, though, for a lot of our pediatric patients, particularly in that adolescent age group, there are a lot of psychosocial factors that perhaps can be better addressed at a pediatric center. And some of this can be insurance related as well. A lot of insurances, for example, in California, CCS, do require patients to be evaluated and assessed at a pediatric CCS center before consideration at an adult center.
Great. There's a question about whether or Stanford, I'm not sure, adult or pediatrics, uses a parental donor, so a single lung or single lobe for pediatric candidate transplantation.
Yeah, so living lobar transplantation, in my understanding, as is not in common practice in the United States. Japan leads the way in doing this internationally. At our center, we do not currently offer living lobar transplantation, and I don't believe the adult team at Stanford does either.
I was curious about, since the audience slightly varied, in terms of what is the role of the referral team and referral center for that optimization period that you talked about. So clearly the things you mentioned in terms of uh, ECLS and ventilation, potentially you as a transplant center may manage, but what's the role of the home institution there in terms of co-management?
Yeah, that's a great question. So if a patient is outpatient and they are referred to us and they're deferred for needing nutritional optimization or needing to better manage their diabetes, we always send a letter with all of our recommendations, and I or someone from our team will reach out to the home institution to talk about our recommendations for optimization. But we don't leave it there. We continue to see these patients on a routine basis so that we can also help facilitate that waiting period to determine if once they are deferred, if they will ultimately be recommended for activation on the wait list.
There's a very technical question, which is it surprised me that you mentioned that some complex congenital heart diseases can also undergo lung transplantation. For cases with reduced pulmonary blood flow like TOF, it's hard for me to understand how lung transplantation works. Are there many reported cases of these patients receiving lung transplant? How are their outcomes? And in those situations, what do the surgeons usually do with the heart?
Yeah, so this is something that we recently started doing. And so our recent patient who had tetralogy of flow that was unrepaired, she was supported with a central shunt. She had very severe pulmonary artery stenosis, effectively had no supply to one side of the lungs and very minimal supply to the other. So her sats were in the 70s at baseline. And so she underwent bilateral lung transplantation with pulmonary artery reconstruction, as well as tetralogy of flow intracardiac repair. Closure of that VSD and RV to PA conduit. And she's doing well. So this is a relatively new indication and new program that we are starting here, given that Stanford has a very robust and well-renowned PA reconstruction program. And something that we're offering for specific patients who have a relatively low MAPCUS collateral burden and ultimately who have good heart function. There's one paper that I'm aware of that was published now over a decade ago with experience out of Washington University in St. Louis, looking at outcomes for this specific patient population. In that paper, there was quite poor outcomes. However, I think this goes back to thinking about who is a good candidate and thinking through with our surgeons how high that surgical risk is.
And next question is, what can you advise for lung and heart-lung transplant for pediatric patients in low-income countries with limited resources?
That is a great question that I'm not sure I know how to answer that, given that I I don't have any experience taking care of children outside of the United States.
Maybe something that can be explored at a future
Yeah.
IHSLT meeting. So next question. Among pediatric candidates for lung transplantation, which pre-transplant factors have the greatest impact on improving the post-transplant outcomes, such as nutritional status, respiratory conditioning, infection control, psychological support? Are there any recent evidence-based protocols that can help optimize their readiness before undergoing transplantation?
Yeah, I think that's a great question. I think honestly, all of the above. But specifically for me, I think that rehab piece, if somebody is so deconditioned that they're not even able to stand up, trying to get them into pulmonary rehab to get them ambulatory in some shape or form, I think is vitally important. Nutritional status, we know in our adult population that being obese, with a BMI greater than 32 is considered in a lot of centers to be a relative or absolute contraindication to transplant, or having a very low BMI, for example, under 16. The data doesn't shake out as well in the pediatric patient population, but something that I think all pediatric centers are looking into. For our center, for patients who have a BMI, for example, that is off the growth curve with a C score, -3, we do try to get them nutritionally optimized to at least be around on the curve and ideally around or above the 10th percentile. So we are pretty aggressive with recommendation of NG placement for nutritional optimization. All of our patients in the pre-transplant period, if they are deemed to be a candidate, are required to undergo physical therapy for that rehab piece. I wish there were more widely available pulmonary rehab programs for pediatrics to help optimize our patients. For all patients, honestly, with underlying chronic lung disease. And we know anecdotally and also just in general that pulmonary rehab can actually help improve lung function as well as 6-minute walk distance.
And I guess on the same line, um, as a community, what has the community thought has contributed the most to the improving survival trends over the eras that you showed in those survival curves after pediatric lung transplant?
Yeah, I think careful candidate selection probably, as well as earlier earlier reactions to abnormalities. Thinking about for me, thinking about, for example, like elevation in donor-specific antibodies, um, oftentimes that can be elevated for a long time before graft dysfunction is seen. And so acting on sort of infection, treatment of donor-specific antibodies, and also for our specifically our adolescent patient population, as well as on all children, a focus on mental health and that psychosocial support, I think has been beneficial to improving outcomes. Um, I think in that adolescent period, it's very easy for, infants and toddlers to take medications consistently if you have a reliable family. But as children age, it becomes harder and harder to get them to take their medications consistently every day at the same time. And so we do see more issues sort of in that time frame. So having a good support system, not only from the medical team as well as family support, mental health support, I think is beneficial for long-term outcomes.
And then lastly, so we talked about pre, but now so after lung transplant, as the only center on the West Coast, As these patients post-transplant return to their home communities, what's the role of these local centers or the referring providers for patients after lung transplantation? And how can they partner with the transplant program?
Yeah, so all of our patients after transplant are required to be local to us for about the first 3 months post-transplant, and we release them to their home environment after that. We try to keep in close communication with their home pulmonary team, and our expectation is that they see their home pulmonary team on a regular basis. They still come up to see us every 3 months or so, but their primary pulmonary team is their home team, right? So if something comes up, if they get sick, if they need to be urgently seen, it is important for them to be able to reach out to their home team. And if complications were to develop, if they need to be admitted more locally, close collaboration and communication, so that we can help triage the transplant side of things, as well as understanding what else is going on while they're down there. If someone is having a transplant related complication, we typically like to have them here so we can keep closer eyes and initiate therapies for that. But we have had plenty of patients who are admitted locally for other complications that we partner with the home team as their transplant physicians. Um, for me in our program, we recognize that it is a hard burden. It's a burden on families and on patients to come here every 3 months, particularly if they're living out of state. So thinking about how we can better partner with the home teams, even for routine visits, so that they may not need to come locally so frequently, is something that we are entertaining and actively working on for the future.
So there are two more pre-transplant questions. One is about for patients bridged with ECMO, what are some key strategies to help reduce complications and maintain functional status during support, and how do these influence post-transplant outcomes?
Yeah. So for our pre-transplant ECMO patients, I think that more than any other patient, that rehab piece is critical. And so how can we get these patients in an ECMO strategy that allows them to stand and ambulate? So that really is in close communication with the ICU team, the ECMO team. How can we support a patient on ambulatory ECMO? How can we reduce the risk of bleeding risk, of infection risk, and things like that? I don't know that I have the best answer for that, but definitely being at a center where there is a strong ECMO program with a focus on ambulation pre-transplant.
This is a long question, but in terms of how does a transplant team balance prolonged waitlist time, accelerated decline in pulmonary cardiac function, the unique immunologic challenges in children, impact of growth and nutrition and long-term graft survival when determining optimal timing of the transplant and deciding between lung versus heart-lung transplant?
Okay, wow. Well, I think that is when that early referral is key, so that we can think through all of these things, ideally before a patient. Is so critical that you're thinking about ECMO and bridging support strategies. Um, I think for us, I definitely, when I take these phone calls from outside institutions and it sounds like someone who needs a transplant soon, I try to get them transferred to our center as soon as possible so we can undergo that workup and think about optimization strategies. Also, there is, for the sicker patients, we may be more lenient with the type of donor that we are accepting as well. So maybe not thinking about donors that perhaps we might not necessarily take for a patient who is sick but not critically so. could be one strategy to help get them to transplant. But of course, um, being on the wait list, the availability of donor, that is kind of a um, not something that we can anticipate, given that we don't know when donors will be available.
Well, thank you, Dr. C, for such a great presentation and discussing all the different questions. And to all the attendees, thank you very much for your attention and attending this webinar. See you next time.
All right, bye-bye.